Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out your program evaluations and turn those back in and give us any ideas that you might have in regards to future topics or future speakers. Today, it's my pleasure to introduce Dr. Bryan Feyen. Dr. Feyen is an internist and a gastroenterologist. He did his GI fellowship at the University of Iowa. He's board certified by the American Board of Internal Medicine and the American College of Gastroenterology. He's been a member of the McFarland Clinic and on the staff here at MGMC since, I believe, January of this year. Dr. Feyen has a special interest in bariatric endoscopy, and he has very kindly accepted the CME committee's request to come and update us today on that topic, and so please join me in welcoming Dr. Bryan Feyen.
Thanks for everybody coming today. I'll try to figure out how to move the slides here in a second. Oops. There we go. So I chose this topic. I do have a special interest in this particular field of gastroenterology, and it's a new field of gastroenterology. It kind of makes sense. We deal with the stomach and gastrointestinal issues that would be involved somewhat with obesity. So I'm just going to briefly provide an overview of obesity. It's not meant to be an in-depth discussion or pathogenesis, but just some background. I'm going to talk about medical therapy, new medications have come out. Any talk about obesity treatment should include the surgical approach to this, this particular problem. And then I'm going to go into what we have to offer endoscopically. And then I have some other procedures at the end that I just call odds and ends and kind of far out there a little bit, aren't approved yet, and I don't know if they're ever will be approved, but they're interesting procedures. Oops. Let's see. So I think we all know this as being a part of the medical community, the different issues that do occur with morbid obesity, coronary artery disease, insulin resistance, diabetes. We see a lot of non-alcoholic fatty liver disease, which in the future is probably going to be another one cause of cirrhosis and also number one cause of liver cancer, sleep apnea, hypertension, gallbladder disease, osteoarthritis. So this particular problem crosses in all fields of medicine. So there's a lot of factors that are involved with the pathogenesis of obesity, and this is a current area of research. There are some issues, as we all know, with behavioral patterns with regards to eating, cultural aspects with regards to eating. I know I have an Italian mother. If I don't eat everything on the plate, there's an issue for several months. So those issues are there. Stress definitely plays a role in this problem. The food availability, if you live in an environment where food isn't easily available, you probably don't eat as much, and that certainly would contribute to obesity if you do live in an area where food is readily abundant. The content of our diet, also important. Physical activity, friends, medications that we tend to put people on can cause weight gain. And the other area that's kind of interesting is gut bacteria. They've done some work on the differences of gut bacteria in people who have actually undergone a gastric bypass versus those who haven't in the obese category. And they're kind of working on actually fecal transplants in those folks to see if that will help the obese people lose weight. So this has been the paradigm of treatment for a long, long time with obesity. I know I sit in the office and I see folks with fatty liver disease, and we talk about, diet and exercise, and the patient's face usually goes blank. And I know, I've been told that myself. So when you tell a patient diet and exercise, you send them out to the world. What exactly does that mean? The next step above that is pharmacotherapy, which has been around for a long, long time, and I'll talk about those medications. And in the past, the next step up would be surgery, and surgeries usually include permanent changes to anatomy. And there was this gap in here between pharmacotherapy and surgery where endoscopy is trying to fill. This is a map of the, this is the most recent map I could find, 2015, of obesity rates. Iowa is around 35%. Those are the dark red states. The Gulf states are horrible, above 40% obesity rates. Probably, well, I know why, because I used to live in Alabama. A lot of fried food and sweet tea. And this is the map of Iowa. And this is an interesting map because if you look at Story County and Johnson County, physically fit, thin, there's probably there's probably a good reason for that. One, I think they included the college kids in both Ames and Iowa City. But the surrounding counties do have a fair level of obesity. So I just brought this slide. I don't want anybody to get caught up too much in the actual data. But when they've looked at maintenance of weight loss, this is a large study, about 20 studies that looked at different, a variety of ways people have tried to maintain their weight loss, because we know usually when somebody goes on a diet to lose weight, the issue is maintenance over time. They compared a lot of these different factors. And dietary supplements, things like Rip Fuel or Hydroxycut, those things are just terrible. They don't do a very good job. Exercise alone, just for maintenance of weight, is not a good option either. It tends to go over time, tends to wane. The medications do a fairly good job of both weight loss and maintenance of weight loss. Meal replacements tend to do a good job too. So instead of eating a meal, people take a shake or something like that. Do have quite a bit of weight loss. But as time goes on, that tends to wane because people started going back to their old diets. So these are the medications that have been available. The amphetamines have been around since the 1940s and well documented to induce weight loss. Some of the medications you may know have been withdrawn, the fen-phen medication. Newer medications in 1999, orlistat, which induces weight loss by causing steatorrhea, a really unpleasant thing. People with diarrhea, gas, bloating, but it's fairly effective. A new medicine that's probably the most effective is the combination of phentermine and Topamax. People on Topamax tend to lose weight, appetite. And to add that with amphetamine, you really get an increased weight loss. Loccaserin is a newer medicine. It involves stimulation of satiety centers in the brain. And the last one is actually a medication that has been used for diabetics. And at higher doses, this causes delayed gastric emptying and can induce some weight loss. So surgical options usually are, the indications are BMI of greater than 40 or a BMI greater than 35 with two or more comorbid conditions like sleep apnea, diabetes, hypertension. And as the surgical options have remained about the same over time, gastric bypass, sleeve surgery, a surgery called a duodenal switch, which I haven't seen in a long time. That can be a brutal surgery. And the lap band, which was popular probably about 10 to 15 years ago. It kind of faded away, but it's coming back. So these are the different surgeries and the results of these surgeries. And the top line is the percentage of each were done. This is old data, 2004, so it's not that important. But what's important is any new weight loss treatment or therapy is going to be compared with these surgeries because they're effective. And as you can see, people with gastric bypass, room-wide gastric bypass, excess weight loss in a year is 70%. That's huge. That's a lot of weight loss. But they also have to consider the significant adverse events, mortality associated with these, and morbidity over time. This has been well documented also. These surgeries do improve metabolic parameters, lipids, blood sugars. People are able to get off their diabetic medications, off their antihypertensives, can stop using CPAP at night. So any newer surgery or any newer procedure is going to kind of be compared to this. So the first area of endoscopic therapy is a balloon therapy. These are indicated for patients with a BMI 30 to 40. The balloons also require intense lifestyle changes in counseling and exercise, or else it doesn't do very well, doesn't work. The advantage of these balloons is that there's no permanent change in the anatomy, very low complication rate, I have some videos showing this pretty soon. On average, American studies for these balloons, about 25% of excess weight loss. In Europe, it's much higher. So I'm not sure if there's an issue with dieting, or I'm sure there is a difference in dieting and those kind of things. But in Europe, they tend to be much higher, 30, 35, 40%. There's currently no insurance that will cover these procedures. I think that's kind of a double-edged sword. When insurance tends to get involved, there tends to be a lot more restrictions on doing the procedure, who can have the procedure, et cetera. So the downside of no insurance coverage is it's a cash payment for the procedure. And like I said, it's an outpatient procedure. People come, they get the balloon placed, and they go home. So there are obviously contraindications to doing these balloons. Anybody who's had previous gastric surgery, gastric bypass, gastroplasty, anybody with cirrhosis, a large hiatal hernia, anybody who needs long-term warfarin or any other anticoagulants. Patients have to take a PPI for 6 months. The reason why it's 6 months is because that's how long most of the balloons will stay in. You do have to screen people for eating disorders or history of eating disorders, and you do that in the clinic before you put the balloon in. If people are unwilling to undergo the counseling for changes in their lifestyle, then that would be a contraindication, but that also brings up ethical issues. There's been reports where people have had the balloon put in, and they're doing great, they're losing weight at 6 months. When it's time to get it out, you can't find them. So what do you do in that case? Any kind of GI inflammatory disease like Crohn's disease involving the upper gastrointestinal tract, active peptic ulcer, and any bleeding conditions like GAVE. This idea has been out for a while, and the original balloon was in 1985, Garrett Edwards balloon. It's basically a cylinder with a hole. It would allow, it would move back and forth in the stomach, and the theory was to restrict what can enter the small intestine. This balloon, or this particular product, was removed in 1992 from the market for 2 reasons. One, it caused a lot of complications, and the other reason, it just didn't work. There was no data to support its continued use. There's actually 5 balloons I'm going to talk about today. The top 2 are FDA approved in this country. The first one is the Orbera balloon. I'll go into more detail about these balloons. The second one, and the newest one, is the reshaped duo balloon. So if one balloon works well, why not 2? The next balloon, a SPATS adjustable balloon, has the advantage. The first 2 can be in for 6 months. The SPATS can be in for a year, and it's adjustable, so that's the advantage for that. The Obalon is a balloon that actually you can place in the office, so you don't need to place it endoscopically. It has to be removed endoscopically. And the last one, the Ellipse, requires no endoscopic placement or removal. So Oberon, the balloon, has been out for a long time. It's been used in Europe and internationally with good results. It's a single balloon. The fill is about 500 to 800 mLs. I think most people have been filling it to about 600 mLs. Usually fill it with saline and methylene blue. The reason why methylene blue is included, because if the balloon ruptures, it will turn the urine green. Patients are told to come in right away. This balloon has to be removed in 6 months. Currently, that's what the FDA approved it for. Any patient undergoing balloon has to have quite a few things done prior to the balloon to avoid some of the problems that can happen afterwards. IV Zofran, Amend is an antiemetic, usually used with chemotherapy. It's awfully expensive. It's about $200 a pill. And then post-procedure, you have to watch these people closely. Hydration is important in the perioperative period, 2 to 3 liters of fluid before and in combination before they leave. Clear liquids for about 24 to 48 hours, and 2 weeks of full liquids. So I think that would be tough. What studies have shown, about 3 to 7.5% of people will request the balloon to be removed early. And that's because some of the symptoms that people can have. NSAIDs need to be avoided during the entire 6-month period, and you have to stay on a PPI. So I'm going to see if I can get this. This is a demonstration of this balloon.
The balloon is inserted through the mouth into the stomach by what is called an endoscopic procedure. The supervising physician will initially look at the stomach through an endoscopic camera If no abnormalities are seen, he will then proceed with the placement of the balloon, which is inserted while it's in its compact, deflated form. The swallowing process involved is made easier with the help of light sedation. Once inside the stomach, the balloon is immediately filled with sterile water through a small filling tube, catheter, attached to the balloon. The balloon has a self-sealing valve, and once it is filled, the catheter is gently removed. And when the balloon is full, it is too large to pass into the bowel. Placement procedure times vary, but it usually takes between 20 and 30 minutes.
This is an actual live case of the balloon being placed endoscopically. I think it's a little bit easier of a thing to understand.
Hi, this is Dr. Trace Curry from Cincinnati, Ohio, Medical Director of Metabolic Weight Loss Centers and Journey Light of Cincinnati. Enter the stomach.
So he's just doing a routine endoscopy to examine the stomach, make sure there's no issues or problems with placing the balloon. Everything looks normal on this procedure. So after that, skip past that a little bit. Looks, and then he brings the scope out. He puts the balloon down on a catheter and follows it back down with the scope. There's the balloon that's not inflated yet. And then he eventually inflates it with methylene blue and saline. I'll do that here in a second. So about 600 cc's usually. It takes a little bit of time to inflate this balloon. You have to put a lot of pressure on the catheter to get the balloon to expand. Fast forward a little bit. So that's what the balloon looks like, nearly fully inflated. And then he'll gently tug on the catheter, and it will release from the delivery device and sit in the stomach. The balloon has to be removed endoscopically. They have a special device that you actually drill into the balloon and aspirate the fluid out. So like I said before, this has been studied quite a bit. It's been proven to be a good therapy, around 25% excess body weight. That includes the program that these companies offer is a 12-month program, 6 months for the balloon, and then additional 6 months of continuing dietary counseling, things like that. So there's been pretty good data with this balloon with regards to effectiveness. The adverse events, I would tell everybody who's having this procedure, they're going to have a little bit of pain and nausea afterwards. And about 2 to 3% of people sometimes require admission to the hospital to help them. GERD is going to be obviously a problem. Some people do suffer some gastric erosions. Around 7.5% do need the balloon removed early, and there is a small ulcer rate associated with this balloon. This is the dual balloon. Like I said, if one balloon works, maybe two would be even better. So basically the same delivery system with the balloons being inflated to 750 to ml total on each balloon. Oops. I had trouble finding actual live cases of this. So similar to the last balloon, instead of one, there's two. The company says this also offers an advantage. If one of these balloons rupture, it won't migrate down into the small intestine, so it'll give you some time to get it out. And this balloon is also removed endoscopically after 6 months is the current recommendation. So they've also done quite a few studies of this balloon. It's been effective for weight loss. The main issue with this balloon has been gastric ulcers. And so they had a problem with the design of the balloon and how it released from the delivery device. There was a rosette on the tip there. And they redesigned that to reduce the ulcer rate to 10%. So it was much higher before they changed it. And that's been the main problem with this balloon is ulcers. If somebody's undergoing an elective procedure, you kind of want to avoid any bad effects from the procedure like ulcers. This is the Obalon balloon. This is different from the other balloons. You can actually get this put in the doctor's office. The capsule's on a string. You swallow. The balloon's deflated. String goes out along with the capsule, and it's filled with air. Some of the music's kind of cheesy, so this is a basic demonstration of the balloon. Once it gets into the stomach, you inflate it. I'm not 100% sure how you know it's really in the stomach and not still in the esophagus. That would make me a little bit worried because it's about for the air balloon it's about 250 cc's. So it's quite a bit of volume and something you probably wouldn't want to inflate into the esophagus. So the rest of that just shows basically how it works. This is an X-ray after the balloon's replaced. The thing about this particular therapy is that you can have more than one balloon placed. So if a patient comes in, you have one balloon in place, they're not losing enough weight, you can put additional balloons in. This is basically a trial that showed that the balloon has been effective for weight loss, similar to the other previous balloons. There's a risk for ulcers. This balloon has to be removed endoscopically, so you go down and pop the balloon, and you pull it back out. This is a newer balloon that's been available internationally. It's an adjustable balloon. It's a balloon that can stay in for a year. The advantage of this balloon is if somebody can't tolerate the volume, you can bring them back and adjust the volume, or if somebody's not losing enough weight, you can add more volume to the balloon. This balloon, I think, is a lot more difficult to deal with. It has a lot of more working parts and would require additional endoscopies to take care of this if you want it filled or removed. So basically the same theory. You blow the balloon up in the stomach, you pull the scope out, you detach, there's a connection there, and it leaves a tail on the balloon. So this is an actual procedure of placing the balloon. I'll try to fast forward it because it takes a little bit of time. The actual process of getting the scope ready involves multiple steps and multiple pieces of equipment to get the balloon correctly on the scope. Oops. I'm still messing around with it. So after the endoscopy is done, the balloon is basically attached to the tip of the gastroscope. And it's gently advanced. And that's quite a bit of hardware to put through somebody's upper esophageal sphincter. It's the actual live picture of the balloon going down. And then this particular balloon offers a pump. So once the balloon's filled, they detach the delivery device, and it leaves this little attachment. So they're pulling the delivery device out, and on the tip there is the end in which you can fill the balloon or take some liquid out of it, depending on how the patient's doing. And they'll eventually put a cap on there. And this is what people have to go through to get an adjustment of their balloon. So the balloon's in there. They don't feel like they're losing enough weight, or they feel too full. They can't handle it, so you have to fish the string out of the stomach, pull the adapter up through the mouth. You can see there's some trauma there. Pull the cap off, fill it, or release some of the liquid, and then basically uncap it, and you push it. Actually, you have to push the delivery device, the end of that thing, back down into the stomach. To me, it seems a lot more involved, a lot more time consuming. Go back down, and you push this back down in the stomach, and you kind of leave that in there, so you can retrieve it again if you need to remove some more fluid or adjust the balloon. Those balloons been shown to be really effective, and like I said, this balloon can stay in for up to 12 months. Studies have shown a 48% excess body weight loss, total body weight loss of 20%. That's a large amount of weight. There are issues with this balloon, valve issues, ulcerations, balloon deflations. There's been some perforations for this because of this balloon. The flapper thing that you can pull out and fill and refill can end up in the duodenum and cause ulceration. So, not quite ready. This is a procedureless balloon. So similar to the balloon that you take in the doctor's office, it fills with air. This is a capsule that you swallow. It's on the tip of a string, and then once you swallow it, then it can be filled with liquid. This was liquid filled. So. Fill it up with liquid. There's a special pump that you can purchase through the company. Pull the delivery device out, and you have the balloon delivered. This particular therapy has been shown to be extremely competitive with the other balloons that have been available. The advantage of this balloon, again, is that there's no endoscopy needed, no procedures. That balloon will degrade over time, and it will eventually rupture, and it will pass. So there's been no associated small bowel obstructions with this. When you take the other balloons out, it requires general anesthesia because of the volume in which you're aspirating. If the balloon ruptures, you want to make sure the airway is protected. So the question I have for that particular balloon, if it just ruptures while you're sleeping, you're laying flat, how much of a risk are you for aspiration for that? I think that's something that needs to be looked at. And then this is kind of going into the area of, I couldn't believe anybody would volunteer to do this procedure. And when I first saw it, I was skeptical, but here it is. So we usually put feeding tubes in for people who can't eat, whether they have esophageal cancer or some issue with swallowing. So somebody thought, well, if we put those in to feed people, maybe we can help people lose weight with them. So basically, it's a PEG tube. It's put in. You have a button that comes out of the abdomen. Patients actually eat. 20 to 30 minutes later, they go to the bathroom. They aspirate their gastric contents into the toilet. They have a reservoir that flushes out the rest of the gastric contents into the toilet. And so, studies have, and this is FDA approved, this is recently FDA approved, 25 to 30% of the calories are consumed or lost through this way. And the aspiration accounts for about 50 to 80% of the weight loss. But what's interesting is that people change their habits. So if you have to go through the trouble of getting up, excusing yourself from the table, and going to aspirate this, people tend to eat less. It's been very effective, particularly studied in the super obese population, BMIs of up to 50. There are risks for complications, pain. There's always going to be some pain, some dermatitis, leakage. These are the typical things we see with any PEG tubes. And what's so interesting about this particular system is that when people ever ask, are you satisfied with this? Somewhat, and some are neither dissatisfied or satisfied. So that's the majority of the people. But when you ask them, would you recommend it? And over 2/3 of the people who have undergone this would highly recommend this to another person. Interesting. So I do. Everybody ate lunch, so be careful here. This is what the patient goes through. Again, bad music. This is a pretty involved process. You've got a weak stomach, don't look. This is an actual patient. Just finished eating. 20, 30 minutes later, there's a stopcock. And there goes the gastric contents into the toilet. Once that's completely emptied, they have the water reservoir that they squeeze into their stomach to wash out any other residual calories and drain it again. So it snaps off from the button that you place with the peg. And I think the company provides that bag for you. I hope so. So as you can imagine, if you have to do that 20 to 30 minutes after you eat, 2 to 3 times a day, you may want to eat less. But this has been effective, and it's been primarily looked at super obese. The advantage of that is that it doesn't permanently change the anatomy of the patient. So if they want to go on later to have gastric bypass surgery after they lose some of the weight, they can do that. And so I think this is probably going to catch on. I couldn't believe it when I saw it, but people will do it. So average costs, it depends on where you live. The balloon, anywhere from $6,000 to $10,000. That includes the balloon placement, removal, counseling, any medications that are involved. Gastric bypass, average about $25,000. Lap band, gastric sleeve. Also, some of the medications can be pretty pricey. Phenytoramine is extremely cheap. It's amphetamine that's been around for a long time. The newer medication, about $150 a month. The diabetic medication, this is the best price I could get for the treatment of obesity. I don't know how accurate that is, but the dose is twice the dose that you use to treat blood sugars. It's an injectable medicine. And I just looked, at Nutrisystem. What's the average cost of Nutrisystem? It's about $240 a month. So, all these things kind of add up. So I'm going to probably go through this pretty quick, so make sure there's no questions. So future procedures on the horizon include endoscopic sleeve gastroplasty. Instead of having the surgery where you have to cut out part of the stomach and kind of sew it together, we can do it endoscopically with a new suturing device. People who have had gastric bypass can gain weight over a period of time. There's new revisional surgery to help people lose weight again. And then I have some kind of bizarre other procedures. So this is the basic theory behind the gastric.
Gastroplasty is a non-invasive endoscopic procedure designed to reduce gastric volume. This animation provides an overview of the latest technique. A coagulation device, such as the argon plasma coagulator, is used to mark the anterior and posterior walls of the stomach along the greater curve. This creates a guideline for the first outer row of sutures. The first row of full-thickness stitches is placed from distal to proximal. A running triangular suture pattern alternates from anterior wall, greater curve, posterior wall, and is repeated for 5 to 6 bites. The anchor is then released and the stitching sequence is cinched tight. The triangular pattern is repeated. A total of 5 to 6 triangular running stitches are repeated in this first row. This suture pattern is designed to maximize the reduction in stomach volume and foreshorten the greater curve. A secondary inner row of interrupted or running stitches is placed following the lesser curve to create the sleeve effect. These plications extend up to the gastroesophageal junction just below the Z-line.
So it looks good, it looks easy, no problem. So I actually have a live case. And this is what, in reality, what it looks like. I've tried to deal with this suturing device. It's a great device, but it can be cumbersome to work with sometimes. Because that, when you start suturing, you start dealing with bleeding, and you're dealing with peristalsis, and which can make things a little bit more difficult. This device can also be used to close, gastrointestinal fistulas, fix perforations that occur during an endoscopy. So it's a multi-use tool. This is when they're burning, just kind of mark where they're gonna put their sutures. Once that's done, this is a special tool that the company makes. It's kind of a drill. It drills down into the gastric mucosa. You pull it back up, and there's a full thickness suture, and you fire the needle through the stomach, and then one suture is placed. And so you just continually do this. The average time it takes probably, the studies have shown, between 60 and 90 minutes. I think that's if you're proficient at doing this. And the suturing device can be a little bit cumbersome. So suture and suture. These people usually spend the night in the hospital. Complication rate is low, but it does not involve incision or anything along those lines. So that's all I'm sure that. I'll go quickly over this. People who have had gastric bypass do gain weight or can gain weight, probably mainly because their pouch gets dilated over time, and their anastomosis also opens up a little bit, so they're able to eat more. The same device can be used to shrink the gastric pouch and also to make the anastomosis tighter. And this is being done already, along with sleep gastroplasty, obviously. I'm going to skip the rest of this one because I want to talk about these newer. This is was a newer product. It's basically a sleeve that's anchored in the bottom of the top of the duodenum and extends down through the jejunum, trying to create a gastric bypass effect. This was studied quite a bit in Europe, and it did pretty well there as far as weight loss. Their other endpoint was hemoglobin A1C reduction, and it did a good job internationally. But when they studied it here, they developed, there was an increased rate of hepatic abscesses. So the trials were stopped, and they're not sure why that happened here and not elsewhere. So this product is not currently available, and I don't know if the company is going to try to get it approved again. This is a far out thing too that I had to bring to everybody's attention: actual magnet compression anastomosis, creating a gastric bypass or intestinal bypass using opposing magnets. So they've studied these actually in animals. They do endoscopy, they place magnets opposing each other, and see dramatic weight loss between the control pigs and the bypass pigs. This is what it looks like endoscopically. And when you deploy it, you kind of meet together with another endoscope. Actually, these magnets can expand once you put in. Day 4, you already have pressure necrosis. Day 12, you see the area starting to heal. And then by 180 days, you actually have a bypass. And they've studied this. They've looked at 10 patients. I don't know how you get people to volunteer for this kind of stuff, but no major complications. There's no lifestyle program that's needed, and there's some significant weight loss there. This is another attempt at gastric bypass. I don't think this will ever be available. But basically, it's a sleeve that goes from the bottom of the esophagus all the way down through the jejunum, creating a bypass effect. And this is the last thing I was going to talk about. This is relatively new. It's not available here. This involves, the main impetus of this therapy is to better control blood sugars and not necessarily weight loss. So studies have looked at the interaction of the duodenal mucosa with hyperglycemia. So the thought was if we ablate the superficial layer of the duodenum, would we get better control of blood sugars? So this device was designed to do that. It's a device in which you go down and you have to inject underneath the lining of the duodenum to raise it up so you don't burn through. The catheter is then put down, and it's actually super hot water that's flushed through the catheter that burns the superficial lining of the duodenum. And they've looked at this, and this is available internationally. They looked over the A1C control. It shows significant improvement. I think, at 6 months, the A1C starts going up a bit. Probably has some remodeling of the duodenal mucosa. The weight loss wasn't particularly dramatic, which really wasn't the endpoint. Steatohepatitis, liver enzymes also improved over time. So there's a segment of endoscopy that's looking for metabolic treatments, controlling blood sugars and such, and it's probably where the future look is also going. So for endoscopic weight loss, there's multiple new options. There's a question about insurance coverage. Like I said, I think it's a double-edged sword. There needs to be some more studies on metabolic outcomes. It doesn't offer it doesn't require permanent change of your anatomy. It's reversible. So whether it's the balloon can come in and come out. If you're not having a major surgery, there's fewer risks. That's all I had. Questions? And nobody's doing the balloons in Iowa.
That was one of my questions. I think the closest is Mayo Clinic here who's doing it, or?
There's somebody in Omaha.
Okay.
They were looking at it at Mercy in Des Moines, but the gastroenterologists are fighting with the surgeons.
Okay.
Who's
Then-
going to put the balloon in? They have bariatric surgeons there, so.
Most of the patients now, 10, 15 years ago, who had the gastric bypass and original surgeries, now we see them, they kind of, most of them gain weight back and kind of, is there any studies on these? And once the balloon is removed, they'll go back to their weight? I don't know how.
Yeah, so there will be people that go back to their weight with any kind of dietary changes. I don't know what I don't have the percentage off the top of my head. But the one of the most important things, besides just physically putting the balloon in, is creating the lifestyle changes over the period of the year you interact with this patient. So the goal is for them to continue those lifestyle modifications. People can have the balloon put back in after 6 months. I think that's defeating the purpose a little bit. But there's a certain percentage of people that are going to gain the weight back, no matter what you do.
Hi, I have a question about the balloons with the tail. What does the tail do? And then the germs and the hygiene. Can you talk about that a little bit with those ones that you empty into the stool?
Oh, yeah.
Thank you.
So, that's an interesting one, and it's been looked at. They've actually transplanted gut bacteria in people who have undergone gastric bypass into people that are obese, because there's a difference in the flora, and it actually results in some weight loss. It primarily has to do with the species of bacteroides that they're finding in these people's stool. And so that's where the hypothesis comes with regards to gut bacteria influencing obesity. I think it's one of the factors. I don't think it's the only factor. As far as the one with the tail, I kind of went through that kind of quick. So this one is the one with the tail. So the purpose of this tail is to be able to pull it back up through the mouth when you're rescoping this person, and either fill the balloon up with more fluid or take fluid out. That's really the only purpose of that tail. It's the only one that you can do that with. It's the only one you can change the volume of the balloon.
Is there a better, what was I going to say? After that one where they empty into the toilet, do they have better behavior modification
Yeah, they do.
long term?
And that tends to be a lasting change. But they've noticed that in these European studies, people don't want that, they don't want it removed because they've lost so much weight and they're doing better. And so they probably extend these people out a little bit longer than what they should. But there is significant lifestyle changes that occur with that. And so with any of these therapies, whether you put them on medications, it always has to include lifestyle modifications and counseling.
And then what about the one where the balloons, do they have, because the stomach is still going to be large when they take the balloons out?
Yeah, so the stomach size is not going to change. What you hope to change is their behavior over the year that you interact with them. So the balloon stays in for 6 months. During that entire time, people undergo behavioral modification and counseling and those kind of things. So the goal is that the balloon is there to offer somebody or people a jump start into losing weight, and also to give them a time or an avenue to get in to see a dietitian as part of a program. So those changes continue over time. Thank you.